la presencia de un invitado extranjero muy importante, gracias a los esfuerzos del servicio de otorrino. Entonces, muchas gracias, doctor Javier Rubio, por esta mañana. Lo dejo para que haga las presentaciones correspondientes.
Bueno, buenos días a todos. El día de hoy vamos a tener la oportunidad de escuchar al doctor SERGIO DEMARINI, neonatólogo especializado en Estados Unidos y especialmente en el área de neonatología. Ha venido gracias a la cooperación peruano-italiana de cooperación internacional. Han estado por el norte, por Piura, por Trujillo y Chiclayo dando esta conferencia. Y estamos aprovechando la gentileza del doctor DEMARINI de darnos también una charla acá en el Perú. Tiene que seguir acá al Museo de la Nación, tiene que dar una charla dentro de un par de horas, o sea que estamos ya con el tiempo. Lo dejo al doctor DEMARINI.
Thank you, Dr. Rubio, for the kind introduction. And I'm a neonatologist, not an otorrino. So I will speak about hearing screen from my point of view. I'm sure you will know, many of you will know more than me about hearing screening, and this is what we do. And there are a few things that we already know. And the things we know are those ones. Hearing loss is frequent, because at least where we live, it's 1 to 2 per 1,000. Risk factors, I mean, there are risk factors, there is a long line of factors, but we diagnose only about half of hearing loss in babies. And if you miss the diagnosis, you will have both language problems and cognitive problems and reading problems. So this is something we should avoid. Way back then, when I used to start my neonatologist training, it was very bad with babies, with babies. So now things are not too bad. So the incidence of hearing loss is coming down gradually. So you see, the profound hearing loss in the EPIC study in 2006, the follow-up is at school age, it's only 0.2%. So it's not very different now from what it is in full-term babies. There are many reasons for that, that we'll talk about later. And this is about the same. We have a slightly higher rate. It's around 0.3, but that's about the same. The thing is, preemies are a heterogeneous population. The problem is, if you go in an intensive care unit, you will have severe problems and you will face our treatments. So babies, term or preterm, that go to intensive care unit will have more problems. But you see, it's getting better here as well, because they used to be, the hearing loss used to be between 2 and 17%. And now it's coming down to 0.7 to 1.5%. Still, I mean, quite high, but not as high as it used to be. So now we have a regional program in place to screen everyone in our region. Actually, there is a national program. I mean, Italy is done, I'm not sure about Peru. It's divided into several regions, and the government of the region has the task to organize everything, or not organize everything, to be honest. How do we screen? What we do is, we have 3 ways to screen babies. For healthy term infants, the baby you have in the regular nursery, we use all the acoustic emissions on the second day of life. Because on the first day of life, you have too many false positives. In the NICU infants, we don't use acoustic emission, we use automatic auditory brainstem response, so ABR. And if you have babies below 1.5 kilograms, then you do the formal ABR, not the automatic ones, at 44 weeks. Because if you screen before that, you have again many false positives. You have to re-screen them. You tell the family, well, maybe your son is deaf. It's not the case. It will catch up later. We still have false positive and true positive, of course. And there is a learning curve. At the beginning, you have many false positives, then you get better as you get along. So if the patient fails, that means fails the screen, not that he is deaf, of course. And we must rescreen. How we do the rescreening protocol in our nursery? If, let's say it's a normal baby, he or she fails autoacoustic fails autoacoustic emission, then we test by ABR. If the baby fails the ABR, the automatic ABR, then we refer to the audiologist. It's beyond our need. And we rescreen both ears, even if the only one failed. And we repeat screening, even if the baby is okay. I mean, it was screened, it was normal. And if he or she comes back with infections or jaundice, hyperbilirubinemia, then those are risk factors for hearing problem. So we repeat screening if we readmit baby for sepsis or for jaundice, high level jaundice. You have to be aware that you are going to miss patients. There's no way you can screen everyone. But you think you do, but in fact you don't. And how do we miss patients? So cases that might be missed are those discharged prior to screening. Usually we discharge by 48 hours, 48 to 72 hours. If the mother wants to go home on the first day, we don't screen. We say, of course, you have to come back, but there's no guarantee that she will come back. Then there are out-of-hospital births. There are very few, but still there are. So no one knows about that. Then you have births across regional borders. We have all the borders with another province. So let's say one is born in one regional province and then goes home before we screen. When we know we have a screen, the other region, they don't know anything about this baby because it was born in another place. If we transfer the baby, especially the one with problems, if you have a sick baby, we screen after he's getting better, not while he is sick. So if we transfer the baby back, usually we do the screening before transferring back, but it's no guarantee there will be follow-up. Vice versa, if the baby is transferred after the first few days, we think the screening has been done in the previous hospital, but it has not been. So we have to be careful about transfers. Finally, either one of the techniques are far from infallible. They can miss the patient. Next. Also, we think, okay, we screen babies, so it's no problem anymore. We screen everyone, so we cannot miss patients. But in fact, hearing loss, as you know better than me, because you are a specialist, hearing loss may be delayed. So we think it was normal at birth, and it will get hearing loss later on. Next. So we have to repeat audiology evaluation. And when do we repeat? Usually between 24 and 30 months. Why we do that? Because there is a delayed onset hearing loss. And who are the candidates? The one who has a cytomegalovirus, toxoplasmosis, neurodegenerative disorders, or, this is quite important, persistent pulmonary hypertension or hypoxia of any kind. Those are the ones who are normal at the neonatal screening, but they get hearing loss within the first 4 years. So they may be okay at birth, may be okay at discharge, may be okay at 1 year, but they will get hearing loss between 3 and 4. Screening, what we do is an easy part. So we don't actually do it manually. I mean, they are automatic ADR, and the nurses do it. So it's very easy for us because we don't do it ourselves. And it's the easy part. The hard part is you find someone who has a failed test, and you should do this. You should be referred the baby within 2 days of confirmation of hearing loss. So you screen, he fails, you rescreen, he fails. Within 2 days you have to send to the audiologist, which is easy to say, but not easy to do. Yes. So this is the hard part. Screening is the easy one. Next. The hard part is to have a centralized referral system, but at the same time to have a local support. Because families and babies do not live near the regional center. They live in remote areas. So they have to have a referral center someplace, I mean, one for every region, but then they have to have support where they live. And this is the hard part. Next. And also, you can miss babies at several points in the system, and so you have to have a single point of entry to intervention. So there must be a place where everyone goes into. So you can have a register and know, I mean, yes, we have everyone that has been referred. We have not missed anyone. Here, in the regional center, I mean, we have one in our hospital, act as a centralized referral system and has to do all this. I mean, it's easy to say, far less easy to do. The audiological testing, the medical evaluation, because there might be otherwise normal babies, but some babies will have lots of other problems. It has to be taken care of by other doctors. Genetic consultation, because about 50% of cases will be of genetic causes. You have to have technicians or professionals who know how to monitor the progression of language development. Which, again, it's easy at a certain level. I mean, if someone speaks or does not speak, it's an easy test. Now, how they progress along the way is something that I couldn't do, and probably most of you couldn't do either. Cognitive functioning. It's not that really hearing problems always cause cognitive problems. But remember, those babies may have other problems that can impact on their cognitive problems. Then, if hearing aids do not work, you have to evaluate the candidacy for cochlear implants. I mean, you have to do it, not us, of course. Then, you have to have someone who manages the regional data, because it's okay to do it in a disorganized way, but you save time and you give a much better, you do a much better job if you have a regionalized data system. And finally, after that, you have to be able to track babies, because someone will go astray. And if you don't have a tracking system, you are going to miss many of them, because they live in remote areas. They have problems to come to the regional center, which may be far away. So you don't see the patients, and you don't know where has it gone. So you must develop a way to track patients. Next. we have seen the referral center, a big center that deals with all the complications. But remember, patients do not live near the referral center. They live in small towns, far away. And they might or might not have the means to come regularly to the city to have a referral. So we have to deal with primary care doctors, which might be good here in Peru, but are not very good in Italy. So we have problem with that. And the local doctor has to do at least two things. First, surveillance. He or she has to monitor progress in the training in the hearing and training of the baby. Of course, has to treat otitis media because the baby already has hearing problems. On top of it, you put recurrent otitis media with diffusion, they'll have additional problems. And has to check the developmental milestones. Does the baby develop normally or has a delayed development? Then has to be aware that you have to refer something. The problem does not end with neonatal hearing screening because you have delayed onset cases, and the index case, the baby with a hearing problem, may have sisters or brothers, and you have to refer them too because there are familiar cases. And you have to evaluate the risk indicators by 2 years. So there is just not congenital hearing problems. Hearing problems happens along the way in our lifetime. So if there is one risk factors, then you have to refer to this baby. Because remember, if you have one or more risk factors, the rate of hearing problem is 10 times higher. 10 times higher. And we have the social services. I don't say anything about that because I don't know how the social services are here in Peru. But I mean, they work. Sometimes they do work, sometimes they don't in Italy. It's important because, again, as I told before, babies may come from poor families that live far away, so they must have some help to come all the way to the referral center. So we should not forget the risk factors. Because there are areas with no universal screening, because babies will be missed, because there's no screening in place. And even infants who pass neonatal screenings may be at risk because they have risk indicators and may have mild forms. And as I told you previously, if you have one or more risk factors, hearing loss is 10-fold greater, so 10 times higher. Lastly, you have to have quality control, which is very difficult. I mean, Italy is not a very organized country because we have excellent services and, I mean, so-and-so services. So you have to have quality control because it's not enough that say, okay, we do a neonatal hearing screen, we have to follow up. Fine, but how do you work? Next. So the quality control comes at several levels. I'm not talking about the quality control at follow-up in the referral center. I'm just mentioning what we do and we have to do as neonatologists. So the screening has 95%, at least 95% of babies has to be screened by 1 month. And the fail rate, whatever you use, either ABR or orthoacoustic emissions, has to be below 4%. Our is about between 1 and 2%. And you have to confirm the problem by an evaluation by 3 months. This has to be done in at least 90% of cases. And if this is the case, the amplification aid has to be put in place within 1 month of confirmation in more than 95% of patients. This is easier said than done. I mean, we all know that. I mean, most babies will get everything by this time, but not all of them. So we have to check that we are doing the proper job. And only with quality control we know if we are doing what we are supposed to do. And all babies are really into the system. Anything that we gynecologists or pediatricians can do to prevent this problem? Next. We have to pay some attention to a few things. Aminoglycoside overuse, loop diuretics, noise in the unit, jaundice, and hypoxia. Next. Aminoglycosides, they can cause irreversible hearing loss due to hair cell death. And alpha toxicity depends on many things actually. Fortunately, it's not very frequent, but depends on duration. The longer you use aminoglycoside, the more likely is that the baby will have hearing problems. If you use diuretics, loop diuretics concurrently, then you have some problems. The underlying disease, if the baby has a asphyxia or let's say cytomegalovirus, then you add up on that. And previous exposure, the ones who are really at risk are the typical patient who are at risk is the one with cystic fibrosis. Why is it that? Because they get aminoglycoside over and over and over again because have all kinds of gram-negatives in the lungs. So they get treated for a long time or for several times, and they will end up having hearing problems. Fortunately for us, serum concentration is not very useful, so we are not asked to do peak or trough drug testing. And remember, there is a genetic susceptibility because this is mediated by mitochondrial mutations. And if you use the once daily dose, this is relatively safe because it is very unlikely the peak concentration will get to the toxic level. So use the once daily dose and you will be fine. Loops diuretics, Lasix, furosemide, they can cause reversible hearing loss, unlike the aminoglycosides. But if you use them concurrently, they can potentiate aminoglycoside toxicity. Someone says that if you use 4 milligrams per kilo per day, this is a safe dose. But on the other hand, you find that if you use half as much, 2 milligrams per kilo per day, this may cause hearing loss if you have other diseases. You have a severe respiratory distress, severe hypoxia, and Lasix add up. So be careful, because those are the babies, asphyxiated babies, in whom you may have to use diuretics because they have renal failure. Think twice before you do that, because they are already at risk because they have respiratory failure, and on top of it, you give probably aminoglycoside, and then also furosemide. There are 3 factors. Noise level in the NICU. I come from a Latin country, so the noise level is usually higher than in the British NICU. But it's not there the issue. The noise at any age can cause damage to the hair cells. It may cause partial hearing loss. There's really little that we can do in practice except use the preventive bioengineering. Now incubators, monitors are much more silent than they used to be. Even ventilators, they don't make enough noise. So if you have the chance to buy different newer kind of equipment, do it, because they are incubators are now below 45 decibels as mean noise level within them. Old ones used to be about 60 to 65. Jaundice, hyperbilirubinemia. So everyone gets jaundice. You may have had kids, you know, they get yellow sooner or later after they are born. So what is the jaundice we are talking about? Infants below 1.5 kilos, hearing loss is associated with bilirubin of at least 14 milligrams per deciliter and prolonged duration of jaundice, not just any jaundice. In term infants, fortunately, there is no difference up to about 27 milligrams per deciliter if, remember, if no comorbidity exists. Because if you have infections or ABO incompatibility or RH disease, sepsis, cytomegalovirus, it's a different story, totally different story. So we have to screen and follow up if exchange transfusion level is reached, even if we don't do exchange. But if there is a very high level, those are the ones who may test negative at the neonatal screening that must be rescreened later on. Finally, hypoxia. This is strongly associated with hearing loss. There is a variable susceptibility, so it's not mandatory if you have hypoxia, you have also have hearing problems, fortunately. Remember that those are cofactors. If you have persistent pulmonary hypertension, then you are at risk in the long term. If we use hyperventilation and alkali to treat hypoxia, those are cofactors. The babies with the low CO2, because we hyperventilate with alkalosis, are the ones who are more prone to develop hearing problems. And remember, they will test negative when they go out of the NICU. They will develop hearing loss between 2 and 4 years of age. So you have to follow them up for a long time. Next. So what can we do in the NICU, neonatal intensive care unit? Next. So what we can do is not much, but it's better than nothing. We can limit the duration and of the repeated courses of aminoglycosides. We should not use loop diuretics concurrently along with aminoglycosides. Try to keep the noise level down in the NICU, and if we are allowed to do that, buy newer stuff that is less noisy than the old ones. Again, easier said than done. We have new and old incubators. And if you have hypoxemic infants, do not hyperventilate. Next. To conclude, screening is the easy part. So what we do, we neonatologists do, it's easy. It's not difficult to screen babies. Intervention within 3 months with the appropriate follow-up is a hard part. So what you, ENT, Otorino, do is the hard part. It's a difficult part. You have to develop a single point of entry to the system so you can monitor things. If they go all over the place, there's no way you can be able to monitor things. And try to develop a tracking system so you know where the patient goes, and a quality control so you know what you do. Thank you. Any questions? So we perhaps have a question and answer at the end, and we do the next speech.